I'd like to talk briefly about the effects that serotonergic antidepressants, particularly the SSRIs and the SNRIs, the selective serotonin reuptake inhibitors, medications like Prozac and Zoloft, and the serotonin norepinephrine reuptake inhibitors, medications like Effexor and Cymbalta, and how the serotonin enhancing properties of those medications, what effect that has on energy level and sleep. Aside from the fact that serotonin tends to calm things down and could actually lead to apathy if there's too much of it, people that are anxious or irritable or angry, they calm down significantly. But if we overshoot, we can end up with apathy and what's called anhedonia, where there's too much serotonin and not enough dopamine. And so those individuals not only are not worried and bothered and stressed, but they also don't get excited and they don't look forward to anything and they don't feel like doing anything and they don't shed happy tears either. So we definitely always aim for a balance. But those psychotropic effects aside, the effects on mood aside, what I want to talk about in this video is the effect that increasing serotonin has on two parameters: energy level and sleep. I'm talking about the level of alertness, the level of arousal versus being somnolent. And so certainly increasing serotonin can lead to somnolence and lethargy as a direct side effect of having all that extra serotonin. Not only are you emotionally calmer, but you're also physically more docile. And so there's a greater tendency to drift off to sleep. But by the same token, it's kind of a double-edged sword. It can make you sleepy during the day, but it also frequently causes middle insomnia and terminal insomnia. Not trouble falling asleep, but waking up a lot throughout the night, or waking up way earlier than you need to before the alarm clock and not being able to get back to bed. So, and that's because of the effects that increased serotonin has on sleep architecture. You just don't sleep as deeply and you're more arousable at night. So people tend to get up a lot, go to the bathroom. They remember their dreams more because they're waking up throughout the night, whereas the dreams that we have at the beginning of the night, we usually have amnesia for. And one clue is if a person is waking up at almost like clockwork, they wake up every morning at 3:30 on the dot almost, and they are wide awake. They go from being asleep to being wide awake. That is very much a medication side effect, as opposed to middle or terminal insomnia, or for that matter, initial insomnia, trouble falling asleep, that a patient might have had as a symptom. Sometimes patients who are depressed, and particularly depression with anxious distress, we see a lot of insomnia, including middle and terminal, but then that converts over from a symptom to a side effect. And then the side effect gets better over a period of weeks, and we can use hypnotic agents to help. But a sleeping pill is really the solution for any form of insomnia, whether it's the beginning of the night, middle of the night, or at the end of the night, in the very early morning. And regardless of how severe it is or whether the person is able to get back to sleep or not, we can use sedative agents. A lot of times we're doing that anyway to calm anxiety, to relax the muscles at night, and some antidepressants are sedating, and sometimes we use them in conjunction with the SSRIs. So that part is fairly straightforward and also easy for patients to understand. The more esoteric principle is that of diurnal somnolence, actual sleepiness during the day as a consequence of these medications. And it doesn't matter whether you take the medicine first thing in the morning or whether you take it right before bedtime. Once you achieve steady state, about 5 days for most of these medications, that you're taking the medication once a day, and you're on a significant dose, a therapeutic dose, so more than just a nominal starting dose. You've gotten past any queasiness or headaches or loose bowel movements you may or may not have experienced. If the medication was selected properly and dosed properly and titrated properly, you really should be able to obviate most of those unpleasant side effects at the beginning. But what you're going to be left with for likely weeks and weeks, and especially if you titrate the dosage, is that diurnal somnolence, the urge to go take a nap. And so at night, it's causing you to wake up a lot and you sleep very shallow. But during the day, if you sit down for a minute, you want a nap. But that's the key. It is a sedentary somnolence. If you stand up, it disappears. All you got to do is stretch your legs and move around, and you won't feel sleepy in the least, and not even tired. It doesn't cause you to feel heavy and tired. If you felt that way, that would most likely be a residual symptom of your depression, psychomotor retardation, and lack of energy, and not wanting to get out of bed in the morning. That's not what SSRIs do. But what they do for people who have sedentary jobs, people who work at desks or long-distance drivers, is that, and particularly in the afternoons, I think that has more to do with the postprandial effect, the fact that people have lunch and then their bellies are full of food, and that tends to make people a little sleepy. It's less to do with the timing of their medication. It has more to do with the dose than whether you take it at dinner time or bedtime or in the morning. But if you're, and there are many factors, circadian rhythm, hormones, there's lots and lots of physiologic factors that determine. But just looking at increasing serotonin, you're going to see a somnolence, an actual sleepiness, an urge to fall off to sleep during the day when sedentary. So if you have an active job, you're not going to experience it. Most likely, it's not going to be an issue. If you're a kindergarten teacher and you're constantly going up to the kids, if you have a job that just involves a lot of walking and moving around and not prolonged sitting at a desk, not answering the phones, not driving, then it's probably not going to be an issue for you. If you have those kinds of occupations, or if you're a student, or just in the evenings when you come home and you sit on the couch for a little bit and you start to nod off, there are workarounds, there are antidotes. I'm not going to get into the actual treatment. I like to tailor that to the specific individual. You have to consider demographics and the epidemiology and comorbid conditions and their physical condition, their age. So I don't want to make any blanket statements about what the best thing to do there is, but I do think a good starting point is the realization that you're only going to be sleepy when you sit down. And if you lie down, you're likely to fall asleep. But then at night, Prozac, Zoloft, they don't particularly help with trouble falling asleep if you have that, and yet they do make sleep more shallow. And so just trying to stay active, stretching your legs. I don't like to recommend caffeine for a lot of reasons, but I will treat sometimes with stimulating medications, dopaminergic medications that increase dopamine, which offsets the serotonin, both by the direct effect that dopamine has, as well as by lowering serotonin levels in certain areas of the brain, by competing with it, or not so much competing, but affecting the level of serotonin. So there are strategies by which we can mitigate that diurnal sedation. And again, it depends on many, many factors, and I always consider the epidemiology and our target symptoms and how well we're doing. Sometimes lowering the dose is an option, but usually just waiting and trying to be as active as possible.